Hello and welcome to the Bpositive Bloodstream, a podcast providing insights, stories and experiences from and for all those affected by acute leukaemia and beyond. My name is Jonjo and I'm the founder of Bpositive and the host of the Bloodstream. So why a podcast? Well, the one thing I lacked when I was diagnosed with leukemia back in 2006 was hearing from people who knew what it was like to embark on a similar journey to myself. It's my hope that by sharing inspiring interviews from people who've either been affected firsthand in some way by blood cancer or who've had similar experiences that others can resonate with, then we can help support those in need. I want these podcasts to provide help, inspiration and belief to all people. Be Positive is both my blood group and my adopted mantra that I held throughout my treatment. I hope you enjoy our interviews, and if you wish to get in touch with us, then please do so by emailing us at info@bpositive.org.uk, or you can find us on Twitter at b_positive_org. In this episode, we discuss both sides of the coin with a diagnosis. How does the consultant deal with having to tell someone they have leukemia? What impact does that have both on themselves and the patient? And what are the best ways to ensure that a diagnosis for blood cancer is handled the best way possible? I was very lucky to grab some time with Adele Fielding, the Professor of Haematology at University College London, and also the patron of Bpositive, as she shares her experiences in having to tell people they have blood cancer and how, despite their responsibility to look after patients medically, it's often the emotional needs that need to be considered. I hope you enjoy. Okay, so I'm with Adele Fielding, patron of Bpositive, and it's a huge coup for us because, as I described in a recent talk, it is like having the Beckham of the haematology ward. I know you won't like me saying that.
I do love David Beckham.
We all do, yeah. But we're really, really blessed to have someone of your expertise on board with Bpositive. But your day-to-day job is a Professor of Haematology at UCL in London, and specialising in acute lymphoblastic leukemia. So when we were just having a chat now about what the best thing was to talk about, we can do a series of different topics, but find it might be interesting to hear both sides of the coin. Having been affected by acute leukemia myself, I only really know my side of the world, and I always find it fascinating to what do the professionals who have to deliver the news and have to train people to deliver the news, what's their taking on a diagnosis, and maybe we can just discuss diagnosis from both sides of the coin, but absolutely take a lead, because I think we often hear patient stories, we don't hear it from people in your position, so I think that personally quite fascinating.
Okay, thank you. And what's really important as well, because obviously we've just spoken together in a session at a conference,
yep.
And it made me think of this particular topic because you referred to specific issues about how you were told that you had leukemia and the sort of different ways in which it finally sort of was conveyed to you, and it sounded like potentially it wasn't done very well. And it's interesting to sort of explore the ways, because obviously for us, we don't necessarily know what the impact of our communications has been until quite a long time after, and sometimes we never find out.
And it must be quite hard to audit that.
It is really. I mean, occasionally, for people who you have a very good relationship with, happy to talk about these sorts of topics, I do go back to people, and say, after a year or so, can you reflect on what happened? Because otherwise we can't really learn.
Yeah.
Because we have to do quite a difficult job of communicating essentially to a complete stranger that they have a life-threatening illness, and not only that, do they have this illness, but they require immediate treatment, so they don't really have any time to think about it.
Straight into it, yeah.
And so I often explain to people, because now I realise that, for example, if you have something like breast cancer, you've often already come to terms with the fact that you may have breast cancer by the time you have diagnosis, because you feel a lump, so you worry about it, but you've got a good idea what it could be, so you go to the GP and you go for a mammogram and everything, and by the 2 or 3 weeks later, by the time you've received a diagnosis of breast cancer, you've already had quite a lot of time to think about it, so that when somebody says, I'm sorry to confirm you've got cancer, you were anticipating that, and you've already had time to anticipate what your response might be, and had time to think about the sorts of questions that you want to ask, and to think about, the sort of support you're going to need from your family.
Yeah.
But mostly people with acute leukemia are diagnosed out of the blue, as it were, so they've generally had only a preceding short illness, and the symptoms are very non-specific.
Absolutely.
As you mentioned, just tiredness and things.
Felt like very heavy flu, and I think there's less awareness of the lookout sign or the watch signs, unlike a breast cancer. A lump, naturally, you might worry.
Indeed, yeah.
It's a bit of a disguised disease.
No young person thinks that they've got leukemia just because they feel a bit tired.
Yes,
you know,
absolutely.
and and rightly, no GP jumps to the conclusion that a young person's got leukemia because it's really rare.
Yes.
So one of the things that people initially say is, I went to my GP last week and he just told me to go home and rest or have some time off work.
Yeah.
You know, why didn't the GP diagnose leukemia? And the truth is, you know, that most GP practices will see one patient in a lifetime. So it's the last thing that they're going to think about.
Yeah.
And so generally, you know, if the GP did a blood test on everyone who came through the door saying they were tired, you know, so they often don't, you know, but if there are specific symptoms like bruising or bleeding or something like that, then that can prompt a diagnosis a bit more quickly. But if it's just a sore throat and tiredness, then, you know, people often wait a couple of weeks.
Would we expect, would we expect a GP, if someone went to their local GP and had the tiredness and bruising, would it be a given that they would automatically think, right, this could be leukemia? Or is it there's so many illnesses, so many different things it could be that...
I think they probably wouldn't think of it, but they might think it could be one of 20 other things.
Right, okay.
That a blood test might be quite helpful with.
Yes.
But generally, in the vast majority of cases, one simple blood test is enough to tell you that there's something significantly wrong with your bone marrow, and possibly to make the diagnosis of leukemia. So if your GP thinks to do that blood test, then that's when the, you know, and so sometimes what happens is GPs will do a blood test, but they, you know, it takes a little while. When you've had a GP blood test, it has to go to the hospital and then the results filter back to the GP. So what will happen is, you know, if they see a very abnormal blood count in the hospital, they will ring the GP straight away and say, you need to contact this patient urgently. But sometimes it's out of hours by the time these blood test results are received. And the hospital will, you know, if they have details of the patient, then, you know, if it's a patient who's already registered, then they will phone the patient personally. But if they don't have details of the patient and they don't really know who it is, then sometimes we even have to get the police involved to go around and, you know, to try and find out who it is and go and get them, you know. So it, you know, it can be quite, because these are emergencies and we wouldn't want anybody to be just left at home overnight. So there's, you know, so how people find out is often in quite a shocking way. You know, because they may have had the blood test and then gone back to work or gone back to bed, depending on how they feel. And you know, then later on in the day, they may get a call from the GP saying there's something very seriously wrong and they need to go to the hospital. And perhaps they get told to take an overnight bag, perhaps they don't, you know. And so that is just an absolutely terrifying situation to be in. I can't really think how somebody would have things going through their minds, you know. But obviously you were in that situation.
I was in that situation, and whilst, God, I mean, there's no better way to be diagnosed in that situation, but I think it would have been worse for me if I got a phone call and had to mull it over and pack a bag and come in. By the same token, I'd gone into hospital not suspecting anything was wrong. I was looking forward to going and getting a McDonald's and just going home. Kept getting delayed longer, as I said in the talk, and I think it will always come, and I think what we're saying is it will always come as a bit of a thunderbolt with leukemia, because it is a shock. The symptoms can be of many of illnesses like flu or cold or something like that. But mine was a shock out the blue, and I was in the hospital, and I didn't leave a hospital then for months on end.
I know.
I hadn't gone back home until I was able to, and that was probably 6-7 weeks until they even allowed me home just for overnight, because they could see psychologically that would benefit for me. That's because I luckily lived relatively close to the hospital. But absolutely, it was unlike, I think it's really interesting here how different diseases, you almost do get slightly prepared for it, or the warning signs are more obvious. It is a disguised disease, and therefore on diagnosis that impact can be huge, but more so because there isn't any time to think. So actually I didn't get time to digest it, perhaps because I was thrown into meetings, getting prodded around, meetings after meeting with different people, getting scared, being passed on from one hospital to the other. There's a lot of different things happening at once, so I describe it as a bit of an out-of-body experience. It felt like that for a while. My feet didn't touch the ground until a good while later.
Yeah, and that doesn't surprise me at all, actually. And the funny thing is, as a physician, when you've been doing this for many years, you know that's going to happen to people, and it's very difficult, you know, because I know when somebody pitches up, you know, on our ward with their overnight bag, that, as you say, they may not go home for several weeks, you know, and I just can't think how horrible that would be, you know, to just be stuck in one room. So I already feel very badly for people because I know what they've got coming and I know they don't know it.
Yeah.
And the issue for me is like how to convey that information in such a way that it's, because you want to be both honest and reassuring at the same time.
Yeah.
And I think one of the, it's quite a difficult balance to get right, because the minute you say something terrifying, and this is something, as I said to you a little while ago, we do get some training, in sort of inverted commas, how to break bad news.
Yeah.
So there are some criteria, that we always try and speak with people in a private place, make sure that they have, if possible, friends or family with them.
Yes.
Make sure that we take with us a nurse or some other a person who can support the patient later and help listen to the conversation. And we also know, and we get told, that when you tell somebody an emotionally devastating piece of information, the high likelihood is that they won't hear what you say next.
Yeah.
So you've got to be very careful what your choice of words are, because.
And is that something you get trained on, or is that just something you pick up with experience?
I think as the more senior you are, the more you can figure out. Because I think when you're junior, one of the things you get taught is obviously that you have to be honest with people, that you have to be very upfront, that you have to allow people to make their own decisions and to consent. But you also know as a senior individual that somebody, who's in their early 20s, who's been told they've got leukemia, and that's all they know, is not going to be empowered and in a position to make a whole ton of decisions, because they're going to be emotionally devastated.
Of course, yeah.
So you need to figure out at what rate you give people information, and it's not the same thing as being economical with the truth. It's just that you can't teach somebody everything about acute leukemia in one 30-minute consultation. So you have to think about what are the key messages that you want to deliver. And I always think it's very important to deliver the key message that it's a curable disease right from the get-go.
Absolutely.
Because if at a later date things don't go well for that person, they're not going to come back to you and say, but you told me it was curable.
No.
But if you don't tell them that straight away, they can just be so devastated that they don't know what to do for the next month. So I would, tell them the diagnosis, and you tell them that the purpose, they have to have treatment, but the purpose of treatment overall is to cure the disease, so that the disease first goes away and then later on never comes back.
Yes.
And I think that's what I try and say within the first couple of minutes,
right.
Because at least, and then it may be possible that someone's calm enough to listen to any other piece of information.
Yeah.
But what I've now learned to do, because I always used to think that I should spend as much time as I can, I could spend 1 hour, 2 hours, but it doesn't always benefit the person. But what it does benefit them, I believe, is to know that you're going to be available at another time.
Yes.
And so I'll generally say, there's only so much we can do today. And I'm going to sit with you, and when it looks to me like you really can't take in another piece of information, we'll terminate this consultation, but I will come back tomorrow.
Yeah.
And what time I'm going to come back.
Digested it a little bit more, taking it in.
And I so now I tend to tell people about these things in a series of short consultations rather than one long one.
That makes
because
sense.
It makes sense, and so I'm able to monitor, how much someone's taken in. And then I'll just overtly say, have you had enough? Have you heard enough already? Or do you need to ask questions, or would you rather we just resume tomorrow? I think it's absolutely critical that people know that they can access you again and again and again. So I always say, it will be me who's in charge of your care. I'm going to be responsible overall, and try and give them an idea that they'll be meeting a lot of other medical professionals and nursing, and also just give them an idea that there's a range of people who they can ask questions to.
There really is a range of people.
Yeah.
I think with my own experience, it felt slightly more, not more, but it felt slightly traumatic, because where I was diagnosed wasn't where I was going to get treated, and where I was treated for chemo wasn't where I had a transplant.
Yes.
Now that became a little bit overwhelming, but I do remember at diagnosis that, as I mentioned in the talk just earlier, that what hit me for 6 was my illness was described as a blood disorder, which doesn't sound as bad as the word cancer or leukemia. And at that point I didn't know what either leukemia or a blood disorder meant, really.
Right.
But it felt like I was getting free hits, because the professor or the consultant who was brought in after hours on the Saturday to diagnose me said, you're very sick, you've got a serious blood disorder. And when he'd left the room and they'd prepared me in the early hours to sleep overnight before I went to Worcester to start with chemotherapy, one of the nurses came to prepare the bed, and she said, and she just dropped in the word leukemia in conversation. And that Friday, I remember seeing my sister's face, and we were shocked. And we were like, no, you didn't say that.
So at that point, you hadn't been told that.
No, I didn't know leukemia was a blood disorder. I certainly didn't know leukemia was a cancer. I didn't know a blood disorder could be a cancer. So when the lady said, yeah, he's got leukemia, and we said, well, what is it? She said, well, it's cancer. It's cancer of the white blood cell, and it's cancer of the blood. And it was like being dealt a blow. Now, I absolutely don't blame anyone. It was more just the shock of hearing it 3 times, because I asked, upon being told I had a blood disorder, I thought, let's get the ridiculous question out of the way, am I going to die? And he couldn't answer, and I think that shocked me more than any words he'd said, is the fact he kind of looked down a bit, put his hand on my arm, despite speaking so sternly, in his thick West Indian accent. I was trying to decipher what he said. He was compassionate, he put his hand on my arm, and I kind of felt, oh, I'm really up against it now.
You really are going to,
Yeah, but I understand that's quite a unique situation, because then when I went to Worcester, I was assigned a doctor from Redditch, and I kept hearing of her when I went to Worcester, but she didn't work at Worcester, she did intermittently, so I had a whole new team first thing in the morning telling me all this news, which has to happen. But I think I just felt overwhelmed because I didn't have a fixed contact to start with. That definitely came and settled, but my actual diagnosis that Saturday night felt quite traumatic, because I was everything was thrown up in the air, and the person who diagnosed me was only brought in as skeleton staff to sort of look at the blood test and tell the news.
Yeah.
And I got the sense of fear, my whole family did, from the people walking around. My mum said she could tell from the staff at the hospital, even before they told me, she just sensed something was wrong, because the way they're almost whispering and saying, look, he's in a bad way, and they don't know.
I think your white cell count was really high as
huge,
well, wasn't it? I hadn't realised that until you gave the talk this morning.
Yeah.
And that's probably why there was such a lot of panic, because when the white cell count's incredibly high, there's an additional risk to just having leukemia, because the white cell, it's like a big, the difference between a runny soup and a big hearty leek and potato soup, Wow. So instead of having consommé running around in your blood, you're having leek and potato soup, and bits of potatoes can get stuck in the blood vessels type of thing. So that's where did they ever do that thing, apheresis, where they took some cells off you to start off with?
I had all kinds of tests to start off with. They wanted to get some DNA from me. They took a trophine.
Did they take off some of your cells using a machine without giving you chemotherapy? Sometimes when the counts, a procedure called apheresis, so they stick a needle in one arm and they take off the cells and they put the
back into the other.
Yeah.
No, I don't think I had
okay,
that, no.
Because sometimes when the white cell count is really high, we do that as an emergency procedure just to get some of them off.
Right. They may have done, or I may have forgotten, but I can't
it's possible, because when your white cell count's that high as well, and it's the same with certain other complications of leukemia, especially if you have a high fever because you've had nasty infection, you can also just not be thinking straight, because your body's not working well. Patients are often incredibly anemic, and so they're very, very tired. So at the very time you're receiving all this information, you're very, your physical weakest as well, and you're genuinely very ill. And so it can be really difficult to know, so I try to, you must tell the diagnosis.
Yes.
And I generally, try and go straight for the truth, a leukemia, a type of blood cancer. But sometimes the fact is you don't know the diagnosis. So occasionally people just come and they have they have a very abnormal blood count, but they don't have any leukemia cells in the blood.
Right.
And so you know that there's something badly wrong with their bone marrow function, but you don't really know whether it's leukemia until you've done the bone marrow test. So in your case, because your white cell count was incredibly high, I'm sure there was no doubt about the diagnosis.
Knew, but they wanted to
for some patients, there is some doubt about the diagnosis. So that's also, in some senses that does give those people a little time to get used to it, because they've appreciated there's something seriously wrong with them and they're not quite sure what it is, but they've been told maybe it is leukemia. Then it maybe give them a day or two to think about it. But I think, when people come through the door and it's really obvious, end of story.
But almost for those people who are kept waiting, they might think, do you know what, it could be good news, and then if it isn't, that could perhaps be playing devil's advocate. That could be worse. There's no rhyme or reason for that.
There's no right way for this to happen, and so you have to. And I think the unfortunate thing is that people do need treatment quite quickly.
Of course they do.
And the treatment regimens, as you well know, are incredibly complicated, potentially quite toxic, and people deserve to know all of the toxic side effects of their treatment. But at the same time, in order to fully appreciate and understand that, it could take weeks, but you don't have weeks to do all of this. So we have, obviously, as you know, a consenting procedure, which is a legal procedure, but the consenting procedure is often somehow seen as separate. I don't know if you had this experience where somebody will come and explain to you about your leukemia, then and if a different person runs in with a consent form, and it has all the drugs with the different chemotherapy names on them.
There was a series
and
of
somebody runs
people.
through a series of things like, this drug could do this to your nerves, this drug could do this to your heart, this drug's going to make you lose your hair. And I don't know that in what sense that's genuinely informed consent, but it's a legal requirement, and I think we do have to do those legal things, but we've got to really think the difference between fully informing somebody, which is a conversation which takes months, and the legal kind of consent procedure that you have to do, because you don't really have a choice. That's the thing, is it?
No,
so if you're having a surgical procedure and the surgeon tells you, I'm going to cut out your gallbladder, but there's a 30% chance I might damage something else. You might decide you don't want your gallbladder cut out, and you'll take your chances. You don't really have that choice with leukemia, because you know that if you don't get any treatment, then the chances aren't good. And so in some senses, it's not the same as informed, because informed consent almost implies you have a choice.
There's a bit of choice with it. I found I was writing my signature all the time because I was having to consent for even when I was having intrathecal lumbar punctures.
You have to consent for each one of those.
Consent for each one of those. And I mean, that strangely didn't scare me. I think even talking about it now probably sounds a bit more scary than actually at the time. I think it was another thing to do. I knew I needed it. I knew the benefits of having it. But as you say, there was no opting out of that, because without that wasn't going to be a good path. I think with things like the intrathecal chemotherapy, for me, I was worried at the science of it, going into your spinal membrane, the nervous system. They hit the wrong wire, that could be curtains. So I think when I ask a lot of questions generally when I talk about, I wanted to know what was going to happen. My mum's very different. She used to say to me throughout my treatment, I don't know how you ask so many questions, I'd turn away and just say, just do what you need to. I wanted to know what was going on, I wanted to know what the drug was doing, just maybe it was to get a semblance of control.
It does give you some sense of control though, I think. I think, and of course I actually love it when patients ask questions. So there's a kind of common myth, I think, sometimes that doctors don't like it if you ask loads of questions. And I feel quite the opposite of that, because I feel like if patients are constantly asking questions, that's really essentially an ongoing consent. And it's
more informative.
And it's really, really, really helpful. And I am terrified when people don't ask questions, because if you explain something like you've got leukemia and blah blah blah, and you say, so what do you like to ask me, and they say I've got nothing, I think, oh my goodness, something's gone wrong here already. So the more questions the better, because it isn't, in the end, I think, the role of a doctor is not to tell someone what to do, but to tell them what the options are.
Excellent.
Great
way of putting it.
And so you're an intermediary rather than a person who actually directs operations.
You're not dictating.
And I think it's really important that you try and have that type of, because you have to have a relationship with people, especially with acute lymphoblastic leukemia. The treatment lasts a long time. And you need to maintain that relationship with people over that period of time, and so you have to get to know them properly.
And also from a patient side, they put all their eggs in the basket of the consultants. They're the people who they've entrusted with all this, and their team obviously. And I think forging that relationship is great. I had a great relationship with my consultant, from Mahendra, because she's very personable. She's like yourself. She can talk to you as a person. I think I've encountered one or two registrars who perhaps weren't, and that's not a complaint. It's just people's personalities are different. But from what you're saying, it sounds like the more experienced you are with it, the more you know the best approach for giving a diagnosis. But I suppose you're probably passing that down to people you have to manage, who are about to embark on all that as well. So do you get them in with you at all?
So that's the another thing which is quite interesting is we do I think it's really important to have sort of junior members of the medical team in the room with you when you're having these discussions with patients, because it's really important for them to observe. because whether you do something badly or you do something well, they can make their own judgment and decide whether they're going to behave like you or behave differently from you. So you can learn from people who do things well and who do things badly.
Yes.
So you need to be exposed. But then I often think sometimes what happens is you go in to talk to a person, and they can be a medical team. And and that's normal practice. You might have your registrar with you, or you might even have an SHO, and you'll have maybe the clinical nurse specialist,
yes.
or and also a nurse from the ward. And so you go in together as a team. And one time I have a patient tell me, that every time we came in as a team, they were terrified.
Yeah. It felt like bad news.
It felt like bad news. And whereas going in with the team is actually more the routine approach. And I would say, well, no, actually, genuinely, if I slip in quietly on my own, then that's when it's...
Actually, yeah, then you want to start worrying.
Then you want to start worrying. But what I've realised over the years, that all the signifiers are just interpreted really differently by different people. So once I knew that this patient would be terrified, if we came in with the team, then I would discuss with them about that and try and get them to the point where they realise that we just work in teams and to stop being terrified.
So you would tailor your approach to the individual.
So you have to get to know people.
Yeah,
for that.
Of course.
So you've got to make sure you don't blow it within the first hour. So sometimes you do blow it, and you realise you've blown it. You say something and you look at someone's face and you think, oh fuck.
Yeah.
Whatever I just said, really wasn't appropriate, or it just for that particular person it hurt them so much. So I think you have to say.
But what works for one person might not work for the other.
So I have to say, oh my goodness, I can see that you're really upset. I must have said something that just hit a nerve. I'm terribly sorry. Do you want, because you have to rescue that, because you're going to be that person's,
go-to.
And you can't afford to. To alienate people. You've got to try and rescue these relationships.
Well, that's great that you do it, because you actually rescue it there and then.
You try to,
you try to.
Well, sometimes people don't say anything, or maybe they don't give anything away on the face, and you don't know that you've done anything wrong.
Yeah.
Maybe you'll never know. Maybe there are hundreds of people that I've spoken to that regret having spoken to me. I don't know.
I'm sure that's
but hopefully you get to a place with people where they're going to tell you.
Yeah. I think that, and the more open the conversation is the better. And I suppose, just as we say, patients are different, consultants, registrars, professors, they're all different. They all have different bedside manner, if that's the right term, or certain personalities that they take forward to delivering. Either way, no one will take bad news that well, I think, because certainly with leukemia, it's going to be a shock. But because it's a lengthy process, I remember the registrar I described as Dr. Doom, just because he was very quite clinical the way he spoke, and it was a bit of an ongoing joke. It just felt like bad news every time I spoke to him. Even sometimes he was saying things I was doing well, like further on in the process, and I thought it just sounds like bad news because of how we presented it. But as time went on, that relationship was forged more. He was the one opening my curtains during my transplant and saying, "Come on, the sun's shining," and things like that. And you start warming to people like that. I was a bit of a very fragile person emotionally, and so I would kind of feel a bit not so much offended by his initial approach, but I'd be a bit more. Well, I'm used to having Dr. Prem Mahendra, who's so warm and friendly, and now this other doctor is different, so you kind of have to get used to it. So having that constant team of people, I think, helps with the process, because you kind of get used to that, and they become a bit of your family in hospital. When you're in isolation.
And one of the things we do try and do is, because we do work in teams, and we do recognise, I think it's just normal human behaviour that different people relate to certain other people in different ways. And we do our best. If we know that patients have a really good relationship, with a certain physician member of our team or a certain nurse member of our team, that we will, do our best to make sure that person gets to see the person we know they like and they feel most comfortable with.
Again, that's tailoring it.
Yeah, but you need to know people a little bit. But what's also interesting is I think it's probably an important consideration is sometimes people, the other thing I always say to people at the beginning is that you're going to ask a lot of questions, and I'm always going to give you an honest answer, but sometimes there isn't an answer. So if I say I don't know, I always say I mean I don't know.
Right.
I don't mean I know, but I'm not telling you.
That's important. Yeah.
I always, because sometimes, and I think it's very hard, especially with our education system, is people aren't really educated well about relative risk, and there's not much general knowledge in the population about sort of statistics. And so people confuse statistics and predicting the future. So the way in which I can tell a person, how it's going to go for them, when they've got a certain subtype of leukemia, there's a range of expectations, that I can say that are based on trials and thousands of other people who've had that condition and that treatment. But I can only say what is likely to happen to an individual, but not what will happen, because that's predicting the future. So there's statistics and there's a crystal ball, and I don't have a crystal ball, and I do have statistics.
And that's that's based on evidence.
Trying to, a lot of people would like you to be able to say what will happen to me.
Yes.
And you can't.
No.
And I say, well, I don't know what's going to happen to me. You might think you're in a worse state than me, but it could be that I die tonight by being mowed down by a car. So we just don't know.
No.
The trouble is, when you're diagnosed with a very serious illness, you're put into a situation where you sort of know more than you should about what your future is. Of course you are.
Well, I had a similar. That's just reminding me of when I was discussing my transplant options. I had to go and hear about the transplant. Again, another traumatic experience. Mum couldn't park the car. I was neutropenic. It was raining. It was just all a bit of a mess. Sent over to Birmingham. My consultant wasn't ready, so I went to chat with the registrar. And eventually, when my consultant came in, we were discussing, and it was still a choice. Now, I was asking those sort of questions. What about me? And they said, we can't tell you what will happen to you. You may not relapse. You may not, if you don't have a transplant. If you choose not to, there's a chance you might not, because we just don't know. History tells us there's quite a likelihood you will, because of how highly you presented.
Yes.
And so, what I wanted was to not have to put myself, because I felt quite well at this point, to go under a transplant which felt highly, I had all the risks spelled out to me. It's highly intensive, it puts you within a couple of % of your life. I heard these different rumblings of things people have said. So I was scared for that, and I thought, if there's a way for me not to have it and be better, that'd be great. And they said, well, there could be, but our expertise and our history tells us a transplant's the best chance of curative treatment for yourself. So I knew I had to do it. I just kind of would almost rather be told black and white, whereas because of my age, I had to make the decision, even though it was pretty much a no-brainer for me, but I still struggled with weighing that up.
And that's the other side of the consent form coin, is that because we so insist, and I think appropriately, on people being fully informed and stuff, sometimes people feel therefore that means they have to direct their own medical treatment, but it isn't like that, you know. And sometimes I have to step back and say to people, we're giving you do have a choice, but there is a recommendation as well. So I'm giving you all this information, and I'm giving you my recommendation, and your choice is whether to take my recommendation, but there is a recommendation. It's not like you're deciding. I'm deciding. I'm telling you what I think you should have, and you can say whether you want it or not. As opposed to, because I think people can be quite upset when they think that they're being asked to decide their treatment. Choice is presented in such a way as if expertise is irrelevant. So expertise is relevant because it's a guide. It's not like you must do this, but it's a guide to helping somebody understand and
same as all the statistics, they're a guide for what history tells us is the best approach. I wanted to, we mentioned before we started recording about the impact of diagnosis. I'd been at the football, I'd gone to hospital, I didn't expect anything, I got hit with a thunderbolt. From your side of it, if you know you're going to work that morning, knowing, what did you describe them as
a new Luke,
which is a new patient about to be diagnosed. How do you prepare yourself mentally for that? Is it tough, or are you conditioned?
It's genuinely tough, actually, especially if you're doing it in an on-call setting, because when you're on call, you have a skeleton team. So the nursing team are all still at full speed and so forth, but you have a skeleton sort of junior doctor team, and the one of the key people in the process, the clinical nurse specialists, they work Monday to Friday. So generally, we'd hope to have a clinical nurse specialist who would then be the first point of contact for the patient. But if we're going in to do this sort of thing on the weekend, we don't have the CNS with us, and we may not often have junior doctor support either, because they're too busy looking after the rest of the patients. So if I go to break bad news on the weekend, which happens surprisingly often, because people are very keen to complete their working week, and before realising that they can't carry on, so it's surprising how many patients pitch up Friday night, Saturday, Sunday. Then I realise, that I'm going to have to tell these people information, and that they might not have all the support systems around, And you're basically going to meet a complete stranger and tell them they have a life-threatening illness.
Yeah.
And you also have to think at the same time, how quickly does this person need treatment? Will I be calling in the on-call pharmacist? Will I be getting chemo made up over the weekend? Do they need any special procedures? How much are they that sick that we need to get in straight away without doing some of the diagnosis? All this type of stuff. So you're thinking about both the personal and the technical at the same time.
Yeah, of course.
Generally, you have a little bit of information. You'll have a referring consultant or doctor who'll tell you, this patient's, you might get an age, generally, the gender of the patient, and you'll know what their white cell count is, and you'll have an idea whether they're ill or not ill.
Yes.
And that's pretty much all you know. So there you are going into, tell a complete stranger.
Right.
And you've got no idea the mental state of that person, how upset they are, the physical state. You don't know anything about their social circumstances. Yeah. You don't know the financial circumstances. That can be a huge issue. If people are self-employed, for example, and they're I had one patient who had recently started up a small business running a cafe, which he ran with his wife.
Yeah.
And, the minute he got leukemia, they couldn't do that business anymore because his wife couldn't manage it on her own and he was unable to work.
Yeah.
So they essentially suddenly had no money, and all that sort of stuff. So there's so many different things that you have to try and take into account. And what's going to strike somebody as the first thing that upsets them isn't always the thing that you would think.
No.
Sometimes people are more concerned about their relatives than they
children
are
or
about
something,
themselves, or they're worried about wanting to tell the kids, or they're worried they won't have any money. And so you just have to, be prepared to sort of try and take all that on board.
That can't be easy because every situation is different, I suppose. And on the flip side of that, I will actually just on the. And does that burden you a bit? You must have had some difficult conversations where I took it badly. I know I took it badly. Well, I think I took my transplant chat worse than my diagnosis.
Right. Oh yes, a lot of people say that.
Because I wasn't prepared for what I was about to hear.
Yes.
And I was in floods of tears. And I remember the faces in the room. They were almost surprised. I'd gone through all this treatment, and I was this surprised. And I think that's because the one team at Worcester hadn't quite communicated to me. That's not a complaint, they're absolute angels, but I was told it was a blood transfusion. And it would be a 15-minute consultation. It was about an hour and 15, and it was the right doctor wasn't there and various things to start with. But I heard my life in numbers, and I didn't prepare for that, and I was fragile. So that sort of made me bewildered, and it really set me back, and I had to pick myself back up again. And I think the being made more aware of that perhaps would have helped, but at the same time another patient might have dealt with that.
You know what, I think your experience is really common actually, and in my previous role I used to be a transplant physician, and so when I was working in the transplant service it was very easy for me to prepare my patients because I would be part of that service and I would already start having those conversations with them. But now I work in a very huge leukemia unit and I don't do the transplant service anymore.
Yeah.
And I have to send my patients to my colleagues for consultations like the one you had. And I recognise the situation, and we often say to them, when you go to the transplant consultation, it's going to be really tough, because they're going to be telling you all the statistics and you're going to hear all this stuff that
at least
you
they're
might
briefed,
so we try and prepare them, because one of my transplant, sounds like it's a pretty black joke as we like in the medical profession, but one of my CNSs who worked in the transplant arena once said to me, that I did a transplant consultation with a patient who came out in tears, and she felt that I'd done a good job, because if you weren't in tears after you'd heard what a transplant was involved, so obviously I think that is a bit of a joke and it was a bit brutal, but it is quite unpleasant hearing those things, and there may be a nicer way of doing it so that people aren't in tears, but the truth of the information
it's unavoidable.
It's unavoidable, because certain people unfortunately do die as a result of transplant, and you have to tell people that.
Of course.
Because
I think it is that reality hitting.
Yeah.
I'd been doing so well with chemotherapy. I was patted on the back all the time saying you're doing so well,
Doing
I was doing
great,
remission, I was doing
yeah.
great. Transplant made me feel like I was going back a load of steps, because it said it's going to give you this percentage chance of dying and this percentage chance of being cured. It just felt like I had a gun against my head. And
I'm
I thought,
not surprised,
God,
yeah.
You know, but again, that's
quite a common
that was the reality.
experience, I think.
Yeah, it is, and but on the other side, I mean, a lot of this is bad news, and how we deal with bad news is more, I suppose, the good side of of the job, well, the positive side, seeing people come out the other end, because there's a lot of good stories. And I think the bad news always makes
it is really
press.
nice.
Oh, and that must affect your day as much as
it's really great. I mean, one
of
of the things is obviously that we do see people in long-term follow-up, and so I, still carry on seeing people that I worked with years ago that are doing extremely well. And sometimes I feel like guilty that they're coming to the clinic. 1 minute, yeah. They're guilty that, they're still coming to the clinic 10 years later.
Yeah.
And I say, do you mind being in follow-up? Would you like to be discharged? And some people only feel good once, when they say we don't need to see you anymore.
Yeah.
They actually enjoy being discharged, and some people would prefer to always have an annual follow-up.
I think I'm
but it's
the latter,
certainly really, really helpful for me, because it's really brilliant to see somebody that you looked after 10 or 15 years ago, and it's absolutely fantastic when all you have to do is chat about how the kids are doing.
Yeah, absolutely.
Blood counts normal, how are the kids?
Yeah.
That's just a brilliant bit of the job.
And that's absolutely fantastic.
Yeah.
I think from my own experience, I think I like the fact that I've got a team there and that I can go for annual checkups. It makes me feel good. And they talk about other patients going through it, saying we saw Jonjo today, and he's 10, 11 years.
It's great.
Since he came
it's
in.
wonderful.
Brilliant.
Well, it's been brilliant having this conversation with you.
It's
You're
great
very
to see
welcome.
both sides of the coin, and we'll hear from you again on other subjects.
Yeah, you're very welcome. Thank you.
Thank you very much.